This meeting is now being recorded.
Hello and welcome to our webinar. We're going to go ahead and get started. You are here for the Working with Interpreters in Behavioral Health Settings webinar. I guess I shouldn't be in front of the screen. Sorry. I want to welcome you to this webinar today. I'd like to welcome Dr. Georgi Kroupin and thank him for the wonderful information he has shared so far in this webinar series, and I'm sure today will be just as informative. Just a reminder that this webinar is being recorded. If you have questions during the session, please enter them in the chat. We should have time to answer questions at the end, and we may also have time to take questions over the phone line. So for right now, everyone is muted, but if we have time, we will open it up to questions over the phone. And I'll turn it over to Dr. Georgi Kroupin.
Thank you. And welcome, everybody. So we're continuing our series now with working with interpreters. I think that it has to be said that the profession of interpreters is way, way underestimated, and interactions with interpreters should be a subject that's discussed in primary care settings, and most importantly with providers. Not just interpreters, not just the support staff. So I've been working with professional interpreters for over 20 years now, and I really enjoy our staff, both because they are very professional, very trained, and also because we were able to forge very good working relationships over the years, because that's, I think, a crucial component of doing work with interpreters. I will try to there are guidelines to working with interpreters and some do's and don'ts, and I will be certainly repeating some of them. However, I will try to present it in the logic of mental health services, specifically psychotherapy. And psychotherapy seems a bit narrow, but I think it's just a model. It's in a condensed way presentation of what's happening in every encounter, in every medical encounter, in every social work encounter. We all people interacting with each other. And if we use an interpreter, then we create some dynamic around the topic or around our presence that needs to be understood and managed properly. First of all, what's so special about working with mental health? I think one of the most important things that, unlike, to a large extent, unlike medical encounters, mental health is focused on the process, not so much on context and content, and focused on experience. It matters much more for me what patient does in the session than what he or she says. I'm watching more for behavioral clues, emotional changes, relational things. And so my focus on here and now, as opposed to even listening to the story or gathering information about the patient. Obviously, there's more likelihood in mental health and dealing with emotionally or behaviorally difficult patients. And in dealing with these issues, we often see how it activates emotional and unresolved personal issues, both in providers and interpreters or anybody who is involved in that. And also, that's on a personal level, but also on a systemic level. When you have 3 or more people in the room, and you talk about emotionally charged stuff, you oftentimes activate ineffective systemic patterns. Basically, everybody brings their family with them. And that's why I'm watching more what happens in the room, not what they talk about. Because people have explanation for things, but you take a look at what's happening in a room with 3 or 4 people, and you see clearly what patterns people bring with them, and it's much more valuable information. But this valuable information also affects me, affects the interpreter, and we'll talk a little bit about how we can manage it properly. to introduce some sort of a logic into approach to working with interpreters, we need to understand what is psychotherapy and what interpreters can do to help make it work. And also we'll talk about specific issues for interpreters themselves to prevent their burnout, because it is a stressful job. Because you're there, but you're not there. You're present, but you're not present. And how do you deal with that? That's always a big question. So, roughly, our work in mental health could be divided in three parts. One part is social control. It's dealing with situations that are threatening or dangerous to self or others, just managing stuff, which is non-specific to therapy. Every provider or anybody who works with patients, kids, anybody else is responsible for that. Mental health stuff could be roughly divided into counseling and therapy, also referred to as first-order change and second-order change in systems theory. Part 1, counseling, is targeted at reducing anxiety and improving stability. It's providing patients with coping skills. It's reducing ambiguity, working on their social adjustment, working on their self-management skills, working on different things to reduce tension in the family, increasing space, communication, conflict resolution, things like that. So basically, it changes things on the surface. It manages things rather than radically alters the way people interact with each other. So, for example, for a family to do a temporary separation, what is it? Okay. For example, to reduce tension in the family, we can introduce some rules in the family where people discuss conflicts only in therapy sessions and they avoid discussing them at home, or we can give them a prescription to discuss certain things at certain times of the day or week, etc., etc. And by following these rigid rules, patient reduce tension and they kind of reorganize the way they deal with conflict, but it does little to what's going on the camera. By doing this, they do little to fundamentally change the way they manage anxiety and relate to each other. Therapy is a second-order change, is changing both inside emotional and behavioral reactions to things, how you perceive people and how you react to things, and changing patterns of behavior in the family. How do you react to conflict, or how do you make decisions about things, increasing flexibility and cohesion, or changing rather flexibility and cohesion in the family. So from that point of view, we'll talk about what goals we have in therapy specifically on individual and systemic level, and how interpreters participate in achieving these goals. We discussed this before, that there's evidence that 85% of success in therapy is attributed to non-specific factors such as safety, trust, availability, and ultimately developing effective patient-provider relationship. Foundations of developing patient-provider relationship in therapy were laid by Carl Rogers, who was an American psychologist in the 40s, 50s, 60s, 70s, died in, I believe, in 87, who came up with a so-called client-centered approach, which had three major components: empathy, unconditional acceptance, and congruence. And many people working in the healthcare field or working with people in general, they know about client-centered approach. We will see how interpreters participate in creating all three components of this approach and what we can do to make it more effective. Empathy is ability to resonate with patients' emotional experience. It's not cognitive understanding of what's happening with the patient is being in his or her emotional field and resonating to it. Although a lot of the time you see therapists nodding their head and going, yes, I understand your feelings. Well, the point is not understanding the feelings and being there present in the session, being with the patient and creating a sense of emotional resonance rather than cognitive understanding. So when we're trying to build that, it's very important also to position people around the room. And, of course, interpreter is an integrative part of this whole arrangement. Their positioning should be out of the emotional space. So when I'm talking to a patient, interpreter should sit somewhere outside of our visual and emotional field. And you see very often this is a basic and fundamental thing that's not working. A lot of the time, because the interpreter is the person who understands the language, the patient is looking at the interpreter, they look at each other, they talk with each other, and then the interpreter delivers some sort of information to me. I'm repositioning and always telling the patient, please look at me, please talk to me. Please look at me. And you have to repeat it 10 times or more before you actually create some kind of a field where the interpreter is outside of this and we're engaged with each other. Because at first it's kind of difficult. It's not sort of intuitive to look at a person who speaks a foreign language and you don't understand what they say. Next thing is do as much as possible, and the interpreter should do that as well, not only physically but emotionally to stay disengaged. It's a very sort of a tricky issue, and I think all of those components should be taken with some flexibility, depending on how much I want to increase or decrease engagement. I may wish for interpreter to be emotionally engaged or disengaged. Sort of I'm talking about specifically mimicking the tone of voice or the emotion behind what the patient says. It could go both ways. I had a very interesting example of working with a provider, with an Italian therapist who was visiting. It was way back 25 years ago in Moscow, who was visiting doing a workshop with us, and he spoke English to our Russian-speaking patients, and in the first half of the workshop we had an interpreter who was very emotionally flat. One of the tools of this therapist was to emotionally engage the patient, and he was right there in the emotional space, but it was not translating through the interpreter, and most of the things he did just went flat. It wasn't working. And then the second I saw that, I was able to replace the interpreter in the second half of the workshop, and it made a dramatic difference. Because his point was, his sort of the hallmark of his approach was curiosity. He was curious. He was very sort of engaging and pulling patients in. And if the interpreter doesn't translate any of that, it's lost. There's no driving sort of a force behind it. Another crucial issue is use of language. Recently, I was working, I may have given a similar example, but recently I was working with another resident who was shadowing me, and she's a medical resident. And I asked her to introduce herself to the patient, and she said, good morning, I'm shadowing Dr. Kroupin here for his psychotherapy sessions, so that something else. And then I discussed it with her, and I say, well, half of what you said is nonsense to the patient. She doesn't know what's shadowing. She doesn't know what's psychotherapy. She doesn't know half of what you say. So watching our language, and it's very polluted with, jargon, medical or psychological, is extremely important. Not only because patients don't understand, Even terms like anxiety and depression, basic terms we use, are non-translatable in many, directly not translatable in many languages. So using terms like, instead of anxiety, saying, are you worried? Are you scared? Are you nervous? Things that are simple, that exist in most languages or sort of more accessible, and not only better understood, they emotionally engage patients. I think use of common language is also extremely important in terms of emotional engagement. Every human condition can be explained in simple human language. And that's the language that directly relates to their personal experience. That's the language that emotionally engages them. And that's the language that they will use to change things, to explain themselves to other people like you do in the family or with other providers or whoever. And that's much more powerful and gives you many more options than using specific terms like anxiety or depression, which is also artificial construct. It doesn't exist. It's a made-up thing that we came up with to create common language in medical mental health community. Lay language also gives access to a huge sort of resource of using humor, using folk wisdom, using proverbs, using metaphors, using different things that are, again, engaging and pulling the patient in, rather than trying to fit him into some kind of a box that we made for our mental health purposes. Just as a side note of using sort of emotions in the language, it is very different. For me, my personal experience is very different when you work in your own language and when you work with an interpreter. When you work with your own language, it's much more emotionally difficult, can be potentially, especially discussing sort of the topics that are important for you personally. I can only imagine how difficult it is for the interpreter to sit there and talk about stuff if they had similar experience. And at the same time, they don't get a chance to participate or share or do anything with it. They need to, just suck it up and carry on, which is an extreme challenge. So we need to be mindful of that. Another difficult topic is use of open-ended questions. A lot of the time, interpreters are trying their best to be very specific and very clear. And at the same time, I know that in some languages, it's really difficult to ask to use an open-ended question or to ask questions using this or that. You need to actually repeat what the patient said and ask them, did you do this action or you didn't? And so a lot of the time it's a struggle to keep it on an open level, which is extremely important for me for many reasons. I will talk a little bit more about increasing patient initiative. When I use an open-ended question, it's important for me to see which direction the patient will choose. For example, I may say, or using this or that, for example, patient may discuss a difficult situation and I will ask, well, when this happens, what do you do? By doing that, I'm leaving it open and I'm leaving it for the patient to choose which part of this experience is more important for him and where he wants to go to pursue sort of the questioning. Instead of leading, I'm pacing and giving him the initiative. At the same time, leaving it open or referring it to this or that creates some ambiguity and elevates anxiety in the session. And We all need to deal with it. I'm trained to deal with it. My job is to deal with ambiguity and anxiety. I am purposefully presenting it to the patient for them to see what happens. But the interpreter's job is just to stay calm and deal with it. Keep calm and carry on, kind of thing. Use this or that has also other meaning. On one hand, you can use it to open it up. On the other hand, this is the only way to relate to directly what the patient said. Each time let's say a patient describes his experience, I don't know, whatever, when the car slammed in another car, and then I had a loud bang, and then sort of I felt a shock and I went numb. So instead of going for description, I would use this. When this happened, what did you feel? I'm trying to preserve his description of the situation as intact as possible. He is giving it to me, I'm giving it back intact to him without altering it by translation. Because if I start describing this situation again myself and go through interpreter again, there's a much greater possibility that we will get distorted in different ways. Transparency, or going back and forth with as little coloring or distortion, is the most important part of the interpreter's job, and we can help them to do that if we work together, understand what exactly we're doing together. This is not their job to clarify what I said or to make it explicit. It's my job to package it and to give it to them so that they pass it on with as little distortion as possible. One of our interpreters once described the job of interpreter as being a bridge. She said that for me, we were discussing what's your image of being an interpreter, and she said that for me, being an interpreter is being a bridge where patient and provider can meet. And I think it's a very good image. Solid, stable, it's just a path where we can meet. But the meeting and the interaction is our business. So that's my kind of a take on working with interpreters. Also, in somewhat similar sense, in therapy, one of the most powerful weapons or tools, I would rather say, is using a pause. Patient says something, and then you stop. And you stop, and you wait. And even in the few seconds now, you can feel like when I stop, the anxiety is elevating and building up and building up. And I need that. I do it on purpose because I need for the patient to be engaged at sometimes, at certain moments. And I need for him to be able to deal with this anxiety, with the elevated anxiety, and then find his or her way of approaching the subject rather than me leading and constantly jumping in and suggesting directions or words. But when you pause, when you don't say anything, you can often see how interpreters, especially those who are not trained and not prepared for it, they get nervous. They look back to me, to them, what's happening? You don't know what to say. So we need to discuss that, and we need to understand that elevating anxiety is one of the most powerful tools. It's an essential part of the therapy process, and we need to be able to tolerate anxiety related to that, and interpreters should be able to do that. Unconditional acceptance. There's a sort of a very common notion that you better find a provider or interpreter with a similar background, similar cultural and ethnic build for them to have better connection and better understanding. It could fire both ways. I have a patient who is a refugee from one of the Arab countries, and he's gay. And he ran because he was gay, because he risked his life every day, because if somebody knew he was gay, he would be executed. So he had a very long history of persecution and trauma and this and that. If I try to match him with a Muslim Arabic interpreter, that would be a problem. There are, other stereotypes or cultural sort of types that don't go well together. Many countries with similar language, they have multiple ethnic groups, and you never know which ethnic group is getting along with the other. A simple example would be even, say, Vietnamese patients. Working with Vietnamese patients, I learned that there are different groups who came to the United States at different times for different reasons. So after the Vietnam War, the first group that was able to escape the war was a group who had physical capacity, who had connections, who had money, who had, ways of escaping the country. But that's a very specific group of people. Most soldiers of the war, they were not able to do that. And there's a tension, used to be at least a tension between the group who came in 1975 and groups who came through re-education camps, who, communist backlash, this and that, and then came later either through the boat, escaping the country, or through the humanitarian operation. There's also a group of North Vietnamese who came to the United States for a completely different reason and with a completely different route, so to say. This is the group who started coming to the United States from North Vietnam, often, again, people who could afford to send their children to school, or, they came for a job or this or that. So people, same culture, same language, same history, but very different background and very different personal experience. And if you're not aware of that, and they, of course, know each other from the first sight, if you're not aware of that, and if you're not, I'm not saying it's impossible, we can work with everybody, but we need to be aware of the differences, and some differences are within culture rather than between cultures. Even on the psychotherapy sort of a side, I find myself a more effective therapist with non-Russian speaking patients, and I think I said something about that before, because with Russian speaking patients it's much more difficult for me to stay differentiated, especially with a certain age group or certain types of patients. I tend to assume more, I tend to identify with these patients more, and that's not a good thing. It may help a little bit in the initial stages of therapy to establish, yes, I know what you mean kind of connection, but on a deeper level, it creates a problem. So it's much more comfortable for me to have some distance to be able to operate from a more neutral and more unbiased stance. In terms of acceptance, again, consequences of differences between what the interpreter's values or experience or take on different things and the patient's experience or preferences are. It's very important for the interpreter to stay neutral, to stay out of the emotional field, to stay out of the conversation, not provide any emotional, behavioral, posture, facial expressions, tone, and everything else, cues that would convey his approval or disapproval of what patient does. And it goes for approval just as much as goes for disapproval. Sometimes interpreters are very happy to see some certain behavior in the patient and they go very approvingly, but you never know what is behind this change and whether this, quote-unquote, positive behavior is helpful and is the right dynamics to go. Maybe it's just enforcing the social stereotype from which the patient is trying to get away. So it is my job to take care of this. It's my job to identify what's right from wrong, and the interpreter is not trained to do that. So the more neutral and the more remote they remain, the easier it is for me to clear the field and to do what I need to do and really create a better partnership. Very important part of Rogerian 3 principles of establishing relationship with the patient or client-centered approach is congruence, and I think congruence is often overlooked. Congruence is the ability of a provider to be present as a person. I'm not there to judge, but I'm there, and at the same time, I'm there to communicate my feelings. If patient says something that scares me, I can tell him, I'm listening to you, but I'm scared. I'm not judging him. I'm saying that I am scared. He may perceive it as judgment, but that's the work of therapy, to separate my emotional subjective reactions from judgment, for him to be able to tolerate the difference with the other person and be okay with it. For him or her to see that this person has a different experience, different attitude towards that, and it's okay. I can still do my job, or I can decide otherwise, not because the provider is getting upset or approving, but because I decide to do so. So my reactions to things may be not understood and not predicted by patient or by the interpreter, and it should be okay with them. That's why, again, I want the interpreter to focus on their task of being transparent and translating, and not be present in the emotional field in any possible way. Now, just a side note, we could develop this further, but just a side note to what was said about the use of language. I think a very important part for me was to understand that language is a tool. Like one of the philosophers who worked with the theory of language, Ludwig Wittgenstein, said, meaning is use. Words mean things depending on how you use them, in which context you put in, what emotional coloring you put to them. The word itself is very broad. It covers a lot of areas, and it's my job to narrow it down and to find the meaning. It's not the interpreter's job. My job is to interpret behavior and emotional conditions through the tools that interpreter gives me. He gives me the picture. He receives the picture, he checks a photograph, and he gives it back to me. And my job is to read this picture. And I can read it depending on the patient and my experience, my sort of professional sort of orientation. Now let's move on to dynamic aspects of the relationship. We talked about the sort of inner stuff, the inside, the inner psychology. Now let's talk a little bit what happens between people in the session, between me and the patient. What's the dynamic between the two people in the session? And there are two levels to that. It's the sort of dyadic level of how patient and I interact around issues, and also systemic level, how all three of us or more with the interpreter are creating a dance in the office, and how this dance affects to what happens and how we can change it or manage it. With the two most important components of the dynamics between the therapist and the patient, or for that matter, any provider and the patient, or any practitioner who works with patients, is battle for structure and battle for initiative. We talked about it before when we discussed major components for therapy, but I think it's very important to take a look at it from the point of view of dynamic in the session and the interpreter's role in it. I think maybe one of the most points I want to make in this talk is that we as providers or we as healthcare workers are completely and totally responsible for the encounter. We need to communicate it to the patient that we know what to do and they can trust us. We don't need help of others, interpreters, in managing patients' behavior, in directing the conversation, in doing this or that. We need to communicate directly that we are competent to manage what the patient is bringing to us, and thus we set the whole structure and the hierarchy of relationship in the session. I think it's one of the most fundamental things, and we'll talk about dynamic in the session and triangulation a little bit more when we deal with it. And I think providers need to be very much aware of that. Battle for the initiative means that patients should be invested in therapy more than therapists. Yes. First, we set the structure. First, they trust us to know what we do, and then they should take initiative. They should come to us and say, I want to change this. I want to work on this. I'm not happy with this. I want to be that way or this way. And then we are helpers, coaches, and sort of people who provide guidance, but it's their job. And I think the role of interpreters in both is extremely important. First of all, what do we mean when we say that the provider is responsible for the encounter? I am the one who is, when we have a conversation, I'm the one who is setting the pace for the conversation. For example, I'm responsible for interrupting the patient in short bits when I feel enough is said for the interpreter to translate. This is my job. I shouldn't wait for the interpreter to say, wait, it's too much. Or for them go for 10 minutes without interruption and give me. I should feel comfortable chopping the conversation into small bits so that it could be easily digested. It's also very important in terms of setting the pace in terms of speed. How fast do we go through topics? How fast we digest the issues? And I think the interesting part is that, yes, the presence of interpretation, the need for interpretation can create obstacles, but at the same time, it's a very powerful weapon or tool that you can use to your advantage. If a patient is hyper, if you feel that they're rushing through things, if you feel that they're too emotional, it's a very comfortable way to slow them down through chopping down the bits of their language, of the information, or sort of whatever they convey to us. So say, wait, let's wait for it to translate. And so you set the pace, and by doing that, you actually communicating very important things to the patient, like, it's okay, you're not going to die, okay? We can manage it. When you sit there and chop it, you communicate the confidence that we're good now, we can deal with this. There's no need to rush it all, et cetera, et cetera. So there's much more than just the speed. You communicate the attitude to the problem and your capacity to manage things. That's why you need to, it's one of the most important things of sort of a structure of the encounter. It's also true for things like repeating questions. For example, if the interpreter says something and the patient goes, huh? So I would like the interpreter to say, huh, to me, instead of repeating the question. Because whatever the patient does, say he is saying, huh, it's a behavioral cue about his condition. That means that he's not paying attention, or he's upset, or he's frustrated, or he's tired. It says something about his behavior, so most likely I won't repeat the question. I will address why he says hi and why he wasn't listening to what was said. If I let the interpreter take the initiative and repeat the question, I'm losing a lot of the information. I'm losing what's happening now at the expense of letting the interpreter taking the lead and managing the encounter, basically. So, and it's all, it's easy to say, but it's not easy to do. You get sort of tempted into a lot of things. So I think we need to be very mindful of those small things, because this is about structure. This is about how we manage the encounter and what we get out of it. And we can't delegate it to somebody else, even a very, highly trained interpreter, skillful and everything. A lot of the time, I think you can, maybe if we had time for a big workshop, I would do a clip where I would ask the audience to try to understand what the patient said without translating it. I think about 30% of the time I can understand what they say without knowing a single word of the language, especially if I'm asking a question that has several options of answers, yes and no, or, the description, or they start describing that they can't sleep because they have pain. Just looking at the person and just, observing their facial and emotional reactions, you can pretty much guess the simple answer. Oh, I couldn't sleep last night because my head was hurting, something like that. Or different other things that are easy to pick up from behavior. And if I see that and I see some discrepancies in what the interpreter says, I will immediately address that. Because sometimes the interpreter is trying too hard to be to deliver a package, to make it digestible for me, for the provider. They want to be helpful, and they simplify or organize this behavior and present this package to me, which I don't need, which means that I lost it, and they're doing my job for me. One of the examples of that was, again, I think I had this example before when I was seeing a patient with delusions, and he was sign language patient, and he was saying something. The interpreter was translating whatever was said, and I could see the discrepancy between the sort of a clear and very compact presentation of the interpreter and pretty much disorganized behavior of the patient. And after a while, I'll ask the interpreter, is that exactly what he is saying? And the interpreter goes, no, but what he says doesn't make any sense. Well, this is exactly what obviously I want to hear. And the interpreter was from the outside, I guess, trying just too hard to be professional and competent and stuff like that. So I think a lot of those things, of course, come with the experience, but I think just being watchful and attentive to that makes a lot of difference. Metaphor initiative. Several things we need to do to facilitate patients' initiative. First of all, patients' ownership of the problem. We are doing a survey, we developed a screening tool for new arrivals in the clinic, screening tool for mental health problems, and at this point we're asking 5 questions, but basically there were 3 basic questions. One of them, do you think you feel sad too much? Another, do you think you worry too much? And then, are any of those things making it difficult for you to do things you need to do every day, functional kind of thing? I think it's very basic, but there are some things that address important issues. One of them is asking, do you worry too much? Everybody worries. If you just ask them, do you feel very sad or very worried, it doesn't give you much information about how they relate to the problem. When you ask them, you worry too much, you get their relationship to the problem. They do worry, but they think it's excessive. And that's where my field of work, not just to reduce their worry, but to reduce the excessive worry. A lot of the worry and sadness is very appropriate, and there's nothing can be done to reduce that. Another thing that's important to create patient's initiative is to use patient's definition of the problem. We need to work with the presentation. We don't impose our sort of understanding on them. We do in a certain way because we choose certain framework, but basically, especially language-wise in the initial stages of, it's very important to use their presentation of the problem and their attempts or their ways of resolving it. What have you tried to do about that? Almost every single session, I'm trying to do it every single session. Although I know the patient very well, seen him for years, each time he comes, I will ask him, what did you plan to discuss with me today? It's not just the information, it's just me giving the ball into his court, giving him the initiative. And a lot of the time you hear, I don't know, I didn't think of it. Okay, that's fine, just let's talk about it, let's discuss, let's make use of our time proper. So I need to make this move, and I'm continuously making this move from me to the patient. Discussing patient's goals and attempts to resolve the issues. In doing all of those important things to maintain patient initiative, use of interpreter should address several issues. First of all, use of ambiguous questions. That opens up the patient's interpretation and their sort of ways of describing their problem. Use their language. If they say something, I may say, what you just said, or I will repeat verbatim what the interpreter gave me to give it back to them, and then ask what they do about it or how they feel about it. So I'm trying to keep their description and their experience as intact as possible and give it back to them. Definitely pacing and leading in terms of chopping the interpretation pieces or taking pause to do that and working on how much everybody can tolerate the pause. Also repeating things over and over again. So, for example, the question, the patient goes in a different direction with a question, and I may decide either pursue the direction he chose, she chose, or I can repeat the same question over and over again to keep them on track, because I think this direction of processing is preferable to that or the other one. And of course, interpreter follows with that. Now let's move on to sort of systemic issues in the process of psychotherapy or any mental health encounter or any encounter in medical or otherwise social work. There's a concept of triangulation that was suggested by Murray Bowen, who was also a therapist. He died in 1990 and worked in 40s, 50s, and he worked on differentiation was his concept, so ability to make decisions independent of emotional reactions of others, of significant others. So you don't get scared because they're angry, or you don't get scared because they're scared. You're scared because you decide it's scary. That's the differentiation thing. But his other important concept was triangulation. He proposed that having a one-to-one relationship is extremely difficult because it creates a lot of emotional tension. And one of the simplest ways of resolving it is to find a third party that will divert the tension of the dyadic relationship. It could be a person, oftentimes it's a child or many children. The more children you get, the more sort of it creates a lot of problems, but at the same time you disperse the one-on-one tension between the spouses. So two, you give attention to the kids. It could be lovers, it could be job, it could be hobbies, it could be friends, it could be drinking, it could be whatever. So any human or non-human third party that will attract emotional attachment, time, and restructure the relationship. That's why a lot of families or immigrants fall apart when they come to the United States because, for example, people stop working and then they stay home just the two of them, 24 hours a day, and nobody signed up for that. That wasn't part of the deal. Yeah, or they used to have a big extended family which would accommodate a lot of tension and pressure, and then they move up here and they just two of them and there's nobody else. And that's too much, and nobody... as we discussed it before, when people come to therapy, they bring their families with them. And it's much more important to observe what happens, how they relate to you or the interpreter. Observe your own reaction, what they pull you into, rather than listening to the narrative, which people can modify according to their needs. Obviously, this happens in the session, and you can see how some people can take on certain roles to accommodate. It's like Legos or whatever, puzzles, where the patient comes with a puzzle, and then he's looking for somebody to match this puzzle to lower the anxiety. Our job is not to do that, not to match the puzzle, but make them more flexible and more open. So it's just not just one, hole that fits the key, but the key is universal. He can relate and interact with different people. But there's a tension and a tendency to match it, to kind of lock it up, to just lower the anxiety of the situation. Our job, a book wrote by Carl Whitaker and Gus Napier, one of the the founding books of family therapy, and it's very interesting. I highly recommend to anybody who has interest in that. It's a narrative of a case study. It's like two people doing therapy. It's called Family Crucible. And the idea is that therapy should be like a crucible that withstands the heat of the melting metal, so that metal can melt and form a different alloy or blend together. So the requirement of a crucible, which is the therapy team, including the interpreter, we need to provide structure. We need to it's one. Two, we need to be able to withstand emotional temperature of the encounter, so that our temperature is of melting is much higher than the family, so we can contain the emotional melting pot kind of thing. And number three, we need to be chemically, like the crucible is chemically non-reactive to the alloy. It doesn't contribute to the mix. We need to be like that. We need to, as much as possible, need to be either non-contributing, or we need to have a control contribution. We need to, like catalyst, we need to know what exactly we're giving them so that it melts. It is a difficult job. It's like any other job. You get trained for it. Interpreters are not trained for this job. They need to be aware, but they are not trained, and a lot of the time they're not prepared for the emotional intensity and for non-reactivity and for structural sort of integrity of the whole thing. And we need to do everything we can to maintain it and work together so that it happens. And includes the things that we already discussed, boundaries and transparency, things like interpreting in the first person and maintaining hierarchy and such. A couple of words about, you were right, we won't have time for questions. A couple of words about safety, but this is specifically for interpreters, and I'm not sure how many interpreters are listening, but we're briefly going to go through that. First of all, some of the time we're dealing with dangerous or kind of a complicated situation, so issues of safety need to be addressed. Interpreters need to be watching for signs of danger and position themselves so that they have exit strategies or they can manage their condition. They need to know when to leave or when to signal distress or how to protect themselves, and the specific things they can do. Limit emotional engagement. they are instructed not to stay in the room with the patient. In any case, when provider leaves the room, a lot of the time they need to leave the room, especially when it's sort of unsafe. And definitely communicate their concerns with providers. Another thing is watching your boundaries and keeping to your niche in this encounter. And that's a very challenging task because a lot of our interpreters, they serve as cultural brokers or they serve as part-time social workers kind of thing. They drive patients to their appointments, they schedule their appointments, they give contact information, they make reminder calls, they help them with this, that, or that, and that increases personal involvement. Technically speaking, it shouldn't happen, but we live in the real world and it happens a lot of the time, so I think we just need to be very mindful of that. That sets a standard for the interpreter to know themselves well and to know how to manage their emotional things, reactions, their behavioral things. For one thing, a lot of our interpreters went through similar experience our patients did, and it's very difficult, and sometimes they find it very challenging dealing with that. We had a couple of people who quit the job because they couldn't do it on a regular basis. I had interpreters who would find it extremely difficult to a point where they need a break. And I'm personally very comfortable with that. I'm very comfortable if the interpreter says, time out, give me a break, 5 minutes. I would rather have them address their issues, go get a drink, walk back and forth, take a breath, and then come back and work, managing it, rather than sitting and just being tense and sort of as a result of that compromising their job. More has to be said, and I think more work should be done. We're doing some of it. I did several workshops for our interpreters. One of them was a couple of months ago or a month ago or something like that. And I think it has to be a regular thing for the interpreters to have the time and right and the capacity to look at themselves, at their emotional and behavioral state, and to take care of themselves and to communicate these needs to providers and the people who manage them. Simple technical things people can do to manage it. First of all, I think it's extremely important to introduce yourself. When the interpreter comes to the room, they should introduce themselves to the provider, to the patient, and do a short speech on what are the rules of interpretation. I always interpret in the first person. I interpret everything that is said. They know what to say. They're instructed to do that. And I think you should stick with it all the time. It sets the structure, it sets your boundaries, and positions yourself both in relation to the patient and in relation to the provider. And, of course, communicate with the provider regarding rules and emotions. Things that we sort of discussed before, but we need to be aware of. Some people come from somewhat different language background, and some of the things cannot be translated or cannot be understood. There are, different dialects in Amharic or Ethiopian language or different other languages that we work with. We need to be mindful of double relationships if they are friends or they know each other somehow through the community or the relatives or whatever. Values-wise, again, we talked about, people having different experiences and values, so we need to be aware of that. And, of course, if somebody went through the same trauma as the patient, that somehow needs to be addressed, and we need to make sure that the interpreter is capable of managing of that. Again, over and over again, I think this is extremely important. The provider or the person who is doing this is responsible for the encounter, including everything. And I think it's our job. It's very easy when tension goes up, it's very easy to try to escape this dual relationship into triangling the interpreter, pulling them into the session and make them partially responsible for emotional or the outcome or explaining things or managing things. Unacceptable. We can't do that. It doesn't work. So this is pretty much it. And we have 1 minute for questions. So I think the most important thing is we need to trust that, first of all, the provider knows what he's doing and the people can manage it. For us to stay calm and differential, we know that whatever people bring to the encounter, they've been dealing with it before, they survived it, they're sitting in front of us, which means that they have the strength to deal with it. We don't need to rush and rescue them. And right immediately, it's our job in the long run to help them live a better life. Thank you.
Thank you. So it is 1 o'clock, and it looks like we probably will not have any time for questions, and I don't see any in the chat box to answer. So I just want to thank everyone for attending today, and just remind you that there is a certificate of attendance that's available. You'll be receiving an email with a link to a survey, so please complete the survey, and the certificate of attendance is at the end of the survey once you've completed it. So that will be open until January 1st. If you have any other questions, you can feel free to call or email the registration email, and I could always forward things on to Dr. Kroupin. And thank you very much for attending today, and I hope you found it valuable. Thank you.